So my name is David Zodda. I work out of the Hackensack University Medical Center. Represent. I bring my own cheering section to all of my lectures. Thank you very much. I just wanted to start off by just giving thanks specifically to SAEM for inviting me to speak here today. I also want to thank all of you for taking time out of your schedule to join me. If there's one thing that you kind of get out of today's lecture, it's that I definitely recommend stealing. Okay? A lot of the information that I'm going to disclose here today has totally been stolen, totally been lifted from other providers, from my former program director in residency to my current program director. I totally encourage it. That's how we get better as providers. Actually, Picasso said that the greatest artists were the greatest thieves. And you need to be smart about it, though. You can't steal from the same person all the time. If you keep knocking over the 7-Eleven, they're going to catch you. Okay, so just being thoughtful about that. So let's think about a little bit of a thought experiment. Let's start with the clinical case, right? You kind of you walk into your emergency department on Monday, you had a nice weekend off, you're feeling chill, you walk in and all of a sudden someone says, "Hey, Dave, you remember that patient you saw?" Raise your hand if you've ever gotten this question, right? Okay, yeah, we've all been there. We've all done it, right? That person says, "Hey, Dave, remember that patient you saw?" You turn around and you're like, "That wasn't for me, man." But guess what? You're Dave. It was you. And it's never followed with, "That patient you saw, yeah, they're doing just great. They loved you. They left you this bag of money." No, it's not quite like that, okay? It's basically, "They ain't doing so bueno, buddy," okay? So what's a doc to do? Let's face it, number one is recognizing that bounce backs happen, okay? We live in a real kind of high intensity environment, right? The reality is that the majority of patients that you see in the emergency department, you're going to discharge, right? That's the reality of it. So how can you try to reduce the number of patients that actually end up bouncing back? Let's look a little bit at the numbers actually. About 3% of the patients that you see in the emergency department are going to bounce back within 72 hours. So what does that mean? Let's actually look a little bit closer. So if you see 33 patients on a given shift, approximately one of them is going to bounce back. Okay, that's a pretty standard clinical shift at Hackensack. What if you did 100 patients? About 3 of those patients are going to bounce back within 72 hours. But if you dig a little deeper, 2 out of those 3 actually end up getting discharged again from the emergency department. So now that leaves you with 1 patient who actually ends up, a bounce back that ends up getting admitted. Okay? So that's 99%. That's pretty darn good. That's what I'm basically telling you guys is that emergency physicians, we're about 99% accurate in determining who should go home and who should stay. But let's not get ahead of ourselves, right? Before you kind of pat ourselves on the back, let's look a little bit deeper into that 1% that actually comes into the ED. You see, this is kind of like a big deal, right? As you know, when you work in your institution, at least our Hackensack institution, all the 72-hour returns are reviewed by a committee. Okay? That means that all those 72-hour returns are going to be reviewed by attending, usually probably a little more senior than you are, to see whether or not Zodda missed something. Okay? And the reason they review it is because there's a lot of money tied to this. Last year, the CMS, the Centers for Medicaid and Medicare, penalized more than 75% of institutions across the country, almost $500 million for 72-hour returns and unnecessary readmissions. So this is kind of a big deal. But is it true? Is it accurate? Do those readmissions, those bounce backs that end up getting admitted, do they actually do worse than patients who were actually originally seen in the ED and admitted? If only there was a study, right? Well, it turns out there is. This just came out in JAMA in 2016. I thought it was a pretty bit of a game changer for me because we always think that these patients that bounce back and that end up getting admitted are terrible. They do awful, right? Well, this study actually looked at outcomes. It was the first study ever to look at outcomes for patients that came into the ED and got admitted and compared with patients who bounced back to the ED and got admitted. And those bounce back patients actually had lower intensive care admissions, lower in-hospital costs, and lower in-hospital mortality. You'll see I have a couple of QR scans throughout this lecture here. If you take out your cell phone and you put on open your camera and you kind of focus on those QR codes, it'll actually kind of send the link to your phone. I'm not very techy. My residents kind of taught me how to do that. If that doesn't work for you, I'll have them in the notes that you can kind of download as well. I also have hard copies up here if you guys want to come after the presentation. So we need to look at that 1%, right? I just kind of showed you a slide that they don't do as terribly as maybe we would have thought so, but we know it though, right? We know when you hear that question, Remember that patient you saw, we know that we've seen bounce backs, right? We know that that patient who was sent home with a diagnosis of anxiety came back with PE. That patient who was diagnosed with renal colic came back with a ruptured AAA, right? This is an actual patient that I saw just a couple of weeks ago. And thank God for the lovely, Greg Henry, who talked about, the road to hell is paved with a diagnosis of gastroenteritis. Don't put diagnosis of gastroenteritis on your charts, please. So how do we predict? How do we figure out which patients are going to bounce back and which ones aren't? Well, I'll be honest with you. I'm the first person to say that I'm not the greatest at predicting things. I was pretty sure I knew who was going to be the 45th president of the United States. Didn't work out that way. Okay, all right. I'm not going to go there for this one, but the prediction business is not the way to go. I suggest we actually start to come up with a process. Create a process to figure out a way that we can evaluate patients even before you discharge them from the emergency department. So what does this look like? I call it the 3 steps to a safe discharge. So step number 1 is identifying high-risk patients. This is a pretty awesome study, 2013. It was done by a group of folks out in California. They've got a great database for all the Kaiser Permanente folks that they see out there. They looked at over 5 million patients that were discharged from the emergency department and bounced back. And they said, what do they have in common? Well, this is what they had in common. These were their high-risk features for folks who ended up bouncing back. Patients who were elderly, patients with chronic renal disease and end-stage renal disease, patients with blood disorders. What I mean by that is I mean sickle cell anemia patients, I mean patients with clotting factor disorders, cancer patients, CHF patients, and what I call vulnerable populations. These are patients with mental health illnesses. These are patients with substance abuse issues. These are also the uninsured or underinsured. So what do we do with this? Do we admit all these people? Absolutely not. But what it should do is it should give you a little bit of pause, because what their study found was that these patients who had these comorbidities and ended up bouncing back, their bounce back rates were 2 to 3 times higher than the general population. So if I just said that the general population has a 3% chance, these folks have anywhere from a 6 to 9% chance of bouncing back to your emergency department. So you identify the high-risk patients, that's number 1. Number 2 is going to be looking at the chart for red flags. And this is something that I really learned as a resident. When I was at Sinai Grace in Detroit, I really felt like it was really impressed upon me to look at my chart, to really make sure that there were no discrepancies. And so this was a great article that came out a few years ago that looked at unanticipated deaths from the emergency department. So that was patients that were actually discharged from the ED, went home, and didn't get bounced back, they died. And they looked back at those charts to find out, well, what did that doc miss? Or what was in that chart that could have potentially been picked up on? And they found these things: abnormal vital signs, imaging, abnormal labs, and chart discrepancies. In 70% of the patients that went home from the ED and died, 70% of them had elevated heart rate, had tachycardia. The majority of them also had imaging and lab findings and discrepancies in their charting that wasn't accounted for. Raise your hand if you've ever gotten a chart that said the chief complaint at triage was chest pain, but the patient came into you with right lower quadrant pain, right? So you need to account for that, right? That's a perfect opportunity for you in your charting to say, nursing note appreciated. However, on my exam, the patient reports no chest pain at all. These are things that we need to appreciate and actually account for in our charting. Specifically, if we're going to send somebody home with abnormal vital signs, right? You have that asthma patient that comes in and you give them albuterol ipratropium, they're feeling a lot better. Their lung exam is smooth and nice and clear now, and maybe they're a little tachycardic because of that beta agonist that you gave them. Account for that. Talk to the patient about that, why their heart rate's a little bit elevated. Document that in your chart as well. These are the things that I kind of really impressed upon you to do in terms of documenting those red flags. So the last thing is a tailored discharge plan. So this was, if you're going to look at any of the articles that I have out here today, I'd probably recommend this one. This was published recently in Annals. It's a survey, right? Annals doesn't publish surveys, but they published this one, which I thought was really cool. What they did was they interviewed folks. They interviewed folks who came back to the emergency department. They actually interviewed the actual bounce back patients, and they said, what's up, dude? Why did you come back here? And so there were 3 things that came from these interviews. The first one was the initial complaint was not addressed. This is verbatim. I told them that my stomach was hurting and that they just gave me medicine to stop vomiting. It wasn't as much as me vomiting, it was that my stomach. They didn't address this issue, and that's why I'm back here today. So what's the key? How do we address this? Well, my take on this is early empowerment. After I see a patient at the bedside and I get a history and I do my exam, I stay there at the bedside and I talk to the patient. This is my assessment and plan. I know that you're coming in here with nausea and vomiting and diarrhea, okay? I know that your vital signs are stable. I know that you look a little dehydrated to me. I'm going to put in an IV. I'm going to give you some IV fluids. I'm going to give you some medicine for the nausea. We're going to get some blood work to make sure everything's okay. I'm going to come back and I'm going to reevaluate you and make sure that you're feeling a little bit better. And if you're better, I can probably give you this nausea medicine to go home with. But let's make sure everything's okay first. You set the tone with the patient right at the bedside, right at the beginning of your workup so that you can do it. So that early empowerment is, I think, a way to really kind of address these complaints. The reality is that their patients are afraid, right? They're not certain what's coming in here. We know what kind of gastritis looks like, right? We know what like IBS looks like, but they don't get it. So I think the way to kind of really empower them early on to try to show them that there's something serious or something not serious going on can really kind of help them through this process. The next one is unclear discharge instructions, and I bet we can all kind of understand this. They just put chest pain, and I'm like, okay, what do they find? They just leave you lost. They take care of you, but they keep what's wrong between them and instead of sharing it with you, right? I mean, I don't need to show of hands, but I'm sure that we've all kind of discharged patients with the diagnosis, abdominal pain, NOS, chest pain, NOS, right? Those patients go home and they read this and they're thinking, but wait, is everything okay with me? What's really going on? So what I recommend using here is what I call teachbacks. And this was actually a really cool study. It did teachbacks for patients who came into the emergency department and see if it actually decreased their bounce back rates. And it did. They actually did a survey as part of this study to try to find out exactly how much patients retain when you speak to them, when you actually give them their discharge instructions. And it turns out that patients forget about 70 to 80% of what you tell them in the emergency department. That's a crazy number, right? So this is, again, where early empowerment can kind of come in here, right? You can kind of, like I talked about, like the beginning when I talked to the patient about like how I'm going to set them up for success. Well, at the end, when they're ready to go, I go to the bedside, and that patient who came in with chest pain, I'm like, look, I know that you came in here with chest pain. I looked at your EKG. It was normal. We got 2 cardiac enzymes. They're both normal. That means that I've risk stratified you, and your chances of having a heart attack are less than 1%. I've got an appointment set up for you with your primary care doctor within the next week. I recommend that you follow up with them. If you have any chest pain, any shortness of breath, if you feel like you're going to pass out, I want you to come back here. I ask them to repeat as much of that as they can for me, and I'm always kind of a little bit surprised that they're able to actually do that. And if they don't, I help fill in the gaps a little bit. I get so much appreciation from my patients from just taking the time to kind of talk them through that rather than just handing them some paperwork that they may arbitrarily read whether or not at home. So that's where the teachbacks kind of come in here. The last part is going to be unavailable follow-up. And so this is another thing. I called the neurologist. They told me that they wouldn't have an appointment until January. So I came back because I'm worried that it's not getting any better, right? We've seen patients who bounce back for this all the time. You kind of go through the trouble of kind of getting them like an appointment, or you kind of give them follow-up information and they're unable to do it. And we have to remember that depending upon where you work, either 1/3 or 1/2 of the patients that you discharge from the emergency department have either no insurance or are underinsured. So the chances of them actually getting to that cardiology appointment is not always going to happen. So what do? Well, I'll put this out here. Follow-up phone calls. So this is something that I learned from like the first day as an attending. I remember when I started at Hackensack, within the first week I went to my first staff meeting. And I sat there. I didn't even know anybody's name. So I sat there and the chairman walked in. He had a stack of papers. And he passed out the papers to all of the attendings sitting in the room. And when I looked at this paper and it had the name of all of the ER attendings listed on them on one side. And then on the other side was their Press Ganey scores. And I thought, well, man, I'm glad that I just started working because I'm not on that list yet. But then I thought, man, this is kind of intimidating, right? And so what my chair did was rather than point to the person who was at the bottom and said, what's your problem? He said, point to the person at the top and he said, what are you doing right? And so I sought that physician out. This kind of gets back to my stealing thing. I sought that provider out after the meeting. And I asked him, I said, Rick, I was like, what are you doing? Like, what's your secret? And this is what he taught me. He taught me about following up with these patients that he discharged. Number one, particularly those patients that you're worried about. Number two, those patients with those comorbidities that I mentioned earlier that are high risk for bounce back. Those are folks, it takes 2 to 3 minutes to call them back the next day to see how they're doing, to make sure they were able to follow up with that neurologist, to make sure that they're feeling a little bit better after you've discharged them. So I put that out there as a tool that potentially folks can use. So I'm going to recap a little bit. Bounce backs happen. 1 out of every 33 patients you see in the emergency department are going to bounce back. 1 out of every 100 that you see are actually going to bounce back and get admitted. There are some things that we can kind of look at in terms of identifying high-risk patients, particularly think patients who are the elderly, patients who have clotting disorders, patients who have end-stage renal disease. There are ways that we can kind of review our charts and really look for red flags, particularly because there's been literature to show that red flags lead to outpatient badness. So making sure that you don't send that patient home with tachycardia unless you account for it. And then the last part is that tailored discharge plan, actually empowering our patients early on in the beginning and then following up with them to ensure that they receive the proper care. I'm fortunate enough to get to work with this group on a regular basis. I'm super grateful for SAEM, and I'm thankful for all of you for being here. And I'll take any questions if you have it. Thank you. Anybody?
I'll second your thing about callbacks.
Yeah.
I just coming out of residency,
Yeah.
I had like one miss, kind of thing. And
Yeah.
after that, I started calling patients back, and you learn so much
Yeah.
from some of the patients that are somewhat marginal that you're thinking about sending,
Yeah.
thinking about keeping, and stuff like that. It's really nice to even to make sure that your clinical gestalt and everything was otherwise confirmed or not confirmed.
Yeah, totally. Thank you for sharing that. I really appreciate that. I felt like one of the reasons I had initially thought about not becoming an ER doc was because I was jealous. I had friends of mine, I had family members who were family docs, and growing up, I got to see them really kind of cultivate a relationship with their patients, really get to see them like work through their diabetes and get off of medications, and we don't have that luxury, right? We see them, and we admit them, or we send them home, and calling back patients, I really, for me, kind of like, not just kind of like made me figure out whether or not I was doing a good job or not, that definitely was part of it, but it also kind of kept some like kind of patient continuity, so I really appreciate that.
We're making it part of our new onboarding process for new things that come through, that we're actually going to set aside some office hours to allow them to have a certain number of patients that they have to call back.
Yeah.
To make it sort of ingrained a little bit, make it more.
That article that I referenced up there, if you guys check it out, I'll put this out on Twitter later on too. I'll put the links out to all my articles. That was also related to Press Ganey scores. It just turns out. So it did show that patient satisfaction totally went up, and actually patients were more likely to refer other patients to your institution if you did those phone calls. Yes?
So I sit on our QI committee, and one thing we struggle with is the difference in bounce backs for like disease progression, right? Like, so someone can bounce back and be admitted, and that could just be because like their disease got worse over the next time, and or for the follow-up example too. Like, I mean, I think you're, at least where I practice, you're delusional if you think all of your patients get a follow-up the next day or the day after.
Yeah.
And we tell every one of them if you get worse to come back.
Yeah.
So I mean, we struggle with that a lot. Was it something that was missed, something that was wrong, or is it just just how this patient was the one who got worse?
Exactly. I mean, I think if you tell your patients to come back if they're feeling better and they bounce back, you're a good doctor, right? I mean, if you see a patient with cellulitis and you say to come back in like 48 to 72 hours so another doc can look at that wound, you're a good doctor. I mean, these are bounce backs that are acceptable. So I get you. I trained at Sinai Grace, and we were every man's doc. We were the OB-GYN, we were the family doc. I know that if I gave them a script and say to follow up for a stress test within the next 72 hours, that's not going to happen, right? But one of the things that I have learned, like in the couple of years that I've been practicing as an attending, is that you find that there are docs out there that do see patients, at least for the first visit, even if they have no insurance. There are compassionate individuals out there, and I keep a running list of them. We just had a great lecture from a rheumatologist come to our residency program the other day, and he said, if you send a patient to me and they don't have insurance, I will see them the next day regardless. I was like, I'm writing down your name. Be careful that you said that, right? So as you kind of go through your practice, find cards, find neuro that are willing to see these patients so that if you did call them back and they can't do it, it'll increase their chances. Are there any other pearls from folks? Because this room, I'm sure, is filled with like years more experience than I have right now. Are there things that other providers do on a regular basis to kind of reduce like the number of patients that bounce back or ensure that patients are going to be well when you discharge them?
I think one aspect of it, right, is it's hard to know how much time you should spend in this. Like you said, in general, you're doing it right. And so then there's some aspect that is patient satisfaction, which is not really our goal outcome. And there's some aspect of not reimbursed, which again is not really our outcome. Our real outcome is like actual bad clinical outcomes. And so, I guess I was hoping against hope there'd be like some magic bullet, you don't miss that one case. Comes back super sick, but it's hard to know how much time you should spend in there because sure you could call all your patients back, your Press Ganey scores will go up, but should that time be spent somewhere else that's more effective? Because in general, we are doing a good job, So and that needle in a haystack effect of that one sick person that you sent home is, it's quantum random.
Yeah, no, I hear you. And it kind of gets back to what this other physician said earlier in terms of the learning that comes with those callbacks. I really feel like that's a big part of it. Yes?
Say non-English speaking patients spend an extra 5-10 minutes with an interpreter at discharge.
Yeah.
There's a lot of patients just don't understand and want us coming back.
You can get your interpreters a lot of times to translate your written instructions too, and I get them to do that too. It doesn't take very much. You just have to sit down and go over it.
Exactly.
It depends on your institution too. It depends if your institution wants to become a primary insurer or just be a hospital anymore. Because where I am, they're working towards being a primary insurer. So then healthcare outcomes make a big difference in keeping them from coming back.
Right.
So they set up mobile health clinics and everything else like that give us free access to, because they realize that we're the front and back door. So they have a real buy-in with us to try to make sure that they don't come back and that they are caught, so to speak,
Right.
and stuff like that. So it depends. Sometimes you have to go bark up the chain of command and be like, look, this is what we need. Say I need a mobile van and have a Spanish interpreter and a PA in there and get it to work. And the cost up front for that is a little bit, but the amount of money you save in the back end by reducing your walkouts left without being seen by even 1 or 2% pays for it 3 times over.
Yeah.
So.
That's really awesome. I'm psyched to hear that because I feel like as physicians, we're clinicians and we're educators, but we can also be advocates, right? Verkhaus said that physicians are the natural attorneys for the poor. And we are basically the societal safety net. We really are. And so we really need to be educators and advocates on their behalf. And that doesn't just mean at the bedside, but it also means kind of at the C-suite level too. Any other pearls from anyone out there? Yes, ma'am.
I'm at UT Health in San Antonio, and we started a partnership with a follow-up clinic with a internal medicine doctor to see them irrespective of these were individuals with ambulatory sensitive conditions that were coming to the ED. We would see them irrespective of their method or ability to pay. And the common thought is that the reason they don't show up to follow-up appointments is because, well, for some of the providers, is that they're not held accountable. So they can come back to the ED and still be seen and not have to worry about the cost. So, well, if they're worried about the cost, what are we doing about it at point of care, at discharge, regarding education on what their financial responsibility was? Because if they kept the follow-up appointment right after as part of the ED visit, it was not an extra cost incurred, and nobody had conveyed that to the patient. So we did have some, assertive follow-up phone calls, bedside education of the patient on what the follow-up visit would entail. We did not, it was not lack of a car or hours or the length of time they're going to stay. If they were willing to go, it was the uncertainty about the financial responsibility at the follow-up visit, because the automatic voice, the robot that called in to remind them of the appointment said, you will be responsible for charges incurred at the follow-up visit. So when we addressed that, the follow-up rate was tremendous. We weren't tracking bounce backs, we were tracking the follow-up rate, but it doubled. We went from 20 to 40% as far as follow-up rates go from the ED, which I think everybody sees. But it was the bounce back. Preventing the bounce back was part of a larger initiative. But you're right; it does take the hospital administration to recognize it, because these weren't permanent FTEs. These were nursing and medical students who were doing the bedside education, and then they moved on. The capacity went with the students. So sustaining the program has been our challenge. I don't know what you can share about how you've been able to sustain the
You know, I think it's sitting right here in this audience right here. It's my residents. I kind of look to them as being the future champions for this initiative. The reality is that callback system that you mentioned, that automated callback system, there are probably a lot of institutions that have something similar to that. I didn't even realize it, but at my institution, I found out a couple months working there that there was a system in place for people to be called back. It wasn't providers who weren't doing it. It wasn't necessarily me who was doing it. And so I think it's trying to find out what institutional practices are already in place And then I think if there's ways to figure out like what those best practices are out there. I'm not sure if like an automated phone call is the key to success there. And maybe it's kind of partnering with like a local kind of community organization that has access to, that accepts patients to come in who don't have insurance or who are underinsured, and to have that plugged into your EMR so that it's easy for your providers to access that and hand that off to patients. So I want to be kind of respectful of time because I know other presenters are going to go, but I just want to say thank you very much for coming today. Yeah.